Okay, so just we'll have some recap of the last session. Okay, so this is the glomerular basement membrane, and what you are seeing here is endothelial cells. These are the endothelial cells, right? And what you are seeing here is podocyte food process, and this is the podocyte. So seeing is the podocyte food process. Podocyte. So in between the podocyte food process, we have a special protein called nephrin. Okay. So then you consider this is the capillary. Above the capillary we have mesangium. Yeah, this is the mesangium. Mesangium has mesangial cells. Mesangium has mesangial cells, and these are the endothelial cells. Okay. Endothelial cells. Okay. Then we have a Bowman's capsule. We have a Bowman's capsule. The Bowman capsules are has a special parietal epithelial cells. Parietal epithelial cell. Parietal epithelial cells. Right. So I told in if it is a child, okay, coming with proteinuria, okay, if there is massive proteinuria like 3.5 grams per day, so we call the child is having nephrotic syndrome. In that case, the changes can be seen in the basement membrane. Changes can be seen in the basement membrane, or it can be seen in the podocyte food process. Podocyte food process, or it can be seen in the podocyte itself, or it can be seen in the nephrin. It can be seen in the nephrin. So this is the nephrin. Okay, so you can see in the nephrin. So if it is seen in the podocyte food process, that is effacement, if it's seen in the effacement of podocyte food process, what it is, there is no immune deposit, no changes in the light microscopy detector, and there is only in electron microscopy it shows loss of food process. Okay, what the disease name? It is called minimal change disease. This is called minimal change disease. And remember, this it is commonly seen in children. If it is adult, we suspect some kind of blood cancer, lymphoma. Okay, we suspect lymphoma. Okay, now if there is change happening in the for example, some kind of again child having proteinuria 3.5 grams per day, and it is a symptomatic proteinuria. What do you mean by symptomatic proteinuria? The child comes with edema. Or complications of nephrotic syndrome. Okay, you all know about complication, right? Because there is a proteinuria, what happens in the blood? The what will be reduced in the blood if there is proteinuria? Albumin will be reduced. Hypoalbumin. Hypoalbumin leads to edema. So edema, because hypoalbumin leads to decreased colloidal osmotic pressure, that leads to edema formation. Then edema formation leads to decrease in blood volume. Right? Decrease in blood volume leads to decrease in renal blood flow. Decrease in renal blood flow leads to renin release. Renin leads to, you guys forgot? See brother.
dyslipidemia and
See, now there is proteinuria, right? There is proteinuria. Nothing need to memorize. Go by logic. Okay. If you know one, you should remember all. Now there is proteinuria. What happens inside the blood? There is decreased albumin. That leads to decrease in colloidal osmotic pressure. That leads to edema, and this edema usually forms in the face and surrounding the orbit because of loose tissue, and this edema is a pitting edema because lymphatics are not obstructed. So if you pit it, it can go into the lymphatics, and if you release your hand, it can come back because the edema again forms. Understand? So that is pitting edema. Now, because of edema, there will be decrease in the plasma volume. Because of decrease in the plasma volume, kidney receives reduced renal blood flow. That leads to hypoxic state. That leads to release of renin. Then renin leads to what? They convert angiotensin into angiotensin 1. Then angiotensin converting enzyme. Actually, this angiotensin converting enzyme sits on the endothelial surface. So if the angiotensin 1 goes in the blood, automatically they get converted into angiotensin 2. Now we got angiotensin 2. Okay. That is you all know. Okay, angiotensin 1 is converted into angiotensin 2. Now angiotensin 2 goes to the do vasoconstriction. Vasoconstriction. That to the arterioles. Okay, that will lead to increased total peripheral resistance. That will lead to increased blood pressure. Okay, now that angiotensin 2 also goes to the adrenal cortex. That will lead to release of increased aldosterone. So aldosterone brings sodium, absorbs the sodium and water. Sodium and water. That leads to increased blood volume. Again leads to increased hydrostatic pressure. Then leads to edema. So this becomes like a cycle. Okay. So then to avoid that, liver becomes compensate. Liver starts producing proteins. They start releasing unnecessary proteins, lipoproteins. That too, they increase the LDL level, they increase the cholesterol level, they increase the triglyceride level, and LDL and increase, then decrease in HDL happens. That is leads to dyslipidemia, and there is hyperlipidemia as well as dyslipidemia. Okay, then the patient becomes atherogenic. 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 So he is prone for he is prone for coronary artery disease. He is prone for coronary artery disease. Okay, now and because now the protein is leaking in the filtrate. Okay, now another protein also leaks if it is a long standing complement. Okay, and that leads to infection. That also you get pneumococcus. And what happens here, another protein gets leaked, that is transferrin. That leads to iron deficiency anemia. Understand? So now because more lipid is coming, that leads to proteinuria. That is leads to lipiduria. Sorry, lipiduria. Okay, lipoprotein leads to lipiduria. So do you know, this patient will tell that I get frothy urine. Okay, yeah, because why? Proteinuria causes frothy urine. Proteinuria leads to frothy urine. Understand? So this is all about pathogenesis of nephrotic syndrome. So if the person comes with any of the symptom, is called symptomatic proteinuria. Okay, now the person is having symptomatic proteinuria and it is a child, and they want to rule out proteinuria. They took a biopsy. What they did? They took a biopsy from that child. They took a biopsy. In that biopsy, there are multiple glomeruli. Okay, now you concentrate on only the glomeruli. In the multiple glomeruli, only some of the glomeruli, this is all capillary. This is all capillary. See, capillary, this is all capillary. This is all capillary. This is all capillary. Okay. Okay, I'm not going to leave you guys until I finish nephritic syndrome. No, you don't have time. Now, what you are seeing in that capillary is some of the glomeruli having some sclerosis. Okay, and so that is focal. It's not seen in the all glomeruli, so it is focal. So this is focal glomerulosclerosis, and it is not seen in the Kullu capillaries. It is seen in a part of the capillaries. It is seen in the corticomedullary glomeruli. Okay, but it is seen in the affected glomeruli. It is seen in the some part of the capillary, so it is segmental. So it is segmental. Okay, it is FSGS. Understand? So this patient will have focal segmental glomerulosclerosis. If it is a children, we think of podocyte injury. Or some protein deficiency in the protein. I'm not going in detail. There are some other problems also in the podocytes. Okay, but overall podocyte injury. Now, if it is adult, you have to think of many conditions. Okay, so one of the condition is obesity. Another condition is reduced renal mass. Another condition is heart diseases. Another most important, which is sickle cell, cyanotic heart disease, are not so common. The most another thing is old people. Old people cancer, you have to think. Okay, old people cancer, you have to think. If it is a old woman, postmenopausal woman, we have to think of any drug they have given for postmenopausal osteoporosis, pamidronate. Okay, and the HIV patient will have this FSGS. Okay, so these are the reasons for FSGS. Okay, now then there is again the person is having proteinuria. Okay, if now it is a again child, and that person, the glomeruli. Okay, so now let us finish this FSGS first. So this FSGS, if you see if you see in light microscopy, you see all these findings, right? Yeah, there is a focal involvement and segmental sclerosis. Okay, but in electron microscopy we see podocyte injury. But immunofluorescence you will not see any deposits. Some trapping will be there, but it is not a real deposit. They are not a real deposits. Okay, now again a child is having proteinuria. Okay, and you are seeing they took a renal biopsy, and you are seeing full of glomeruli. Okay, and that glomeruli. Okay, just I am going to draw one glomeruli little bit big. Okay, in that glomeruli you are seeing lot of capillaries. You are seeing lot of capillary tuft. You are seeing lot of capillary tuft. In that capillary tuft, the problem is you are seeing some kind of thick basement membrane. Some kind of thick basement membrane. Some kind of thick basement membrane. Okay, the endothelium looks normal. The endothelium looks normal, and there is no any damage to the endothelium. And podocyte food process you can't see in light microscopy. So podocyte looks normal. The podocyte looks normal. The podocyte looks normal. The podocyte looks normal. And the mesangium also looks normal, no problem, because this is the mesangium. Mesangium having one or two cells, no cellularity. Mesangium looks normal. And only thick basement membrane you are seeing. In some glomeruli capillary, you are seeing some spikes. Some spikes. You are seeing some spikes. You are seeing some spikes. Okay. Now you are suspecting thick glomerular basement membrane and spikes. You are suspecting membranous glomerulopathy. So it is not enough. You know membranous glomerulopathy is a immune complex disease, but you also know this immune complex will not create inflammation, and you are going to see in immunofluorescence a striking fluorescence just below the epithelium. You are seeing the fluorescence staining, then you are confirming it is a immune complex disease that is creating thick basement membrane and spike. And this immune complex disease, the antibody is IgG or IgM directed against the phospholipase A2 receptor. Phospholipase A2 receptor. Got it? So that is the pathogenesis, and you saw in the in electron microscopy you see thick basement membrane, again spikes you can see, and again you can see deposits in the subepithelium. Okay, so but in immunofluorescence you get striking subepithelial deposit. Okay, it is granular deposit. It is granular deposit. Okay, so this is what you see in all the glomeruli. You will see in all the glomeruli you will be seeing. In all the glomeruli you will be seeing. So that is the another characteristic feature of membranous glomerulopathy. You will not miss in any glomeruli. Okay, it will be diffusely seen in all the glomeruli. So what is this? It is membranous glomerulopathy. Membranous glomerulopathy. Okay, now what else we discussed? Yeah, so now there is a adult. For example, even in this case, if it is adult, what you suspect? You have to suspect. First thing you have to suspect infections, hepatitis B, malaria. These two are very common. Apart from that, it can come in even like FSGS. It can come in many conditions, but you have to suspect infectious first. If it is a female, you have to suspect autoimmune diseases. Autoimmune diseases. Understand? So don't forget about it. Okay, you have to suspect autoimmune diseases, especially if it is a female. Understand? Because in female, autoimmune diseases are more common in females. Okay, now then what the case we discussed. What we discussed?
Diabetes and amyloid. And amyloid nephropathy.
Okay. So what we have to discuss? We discussed about some adult case. Okay, and we discussed about an adult. Okay, having massive proteinuria. Massive proteinuria. Okay, adult cases having massive proteinuria. So what it shows is they took a renal biopsy. Okay, in that renal biopsy you are seeing lot of glomeruli. So in that glomeruli you are seeing capillaries. Okay, the capillary is showing basement membrane thickening. Okay, and you also, in the meanwhile, when the renal biopsy they are taken, you also got a other results. That results is showing increased glucose level, and okay, in the urine microalbumin is increased. Microalbumin also increased in the urine, and there is albuminuria, massive albuminuria. Okay, now you are seeing in the biopsy thick glomerular basement membrane, as well as mesangium is also thick. Okay, and some of the glomeruli, okay, this is capillary, thick capillary, and some of the glomeruli, and you are seeing nodules. You are seeing nodules in the mesangium. Okay, in the mesangium you are seeing nodules, and some of the glomeruli. This all can be seen in single biopsy. That's what I am drawing like this. Okay, in some of the glomeruli, you are seeing complete collapse of the capillaries. Okay, it is completely sclerosed, global sclerosis. In some of the glomeruli, it looks normal. Okay, it is normal. Some of the glomeruli, it looks normal. Okay, because GFR is maintained. Okay, GFR is not collapsed. Okay, so what you are seeing is, now I am seeing complete global sclerosis. Hello? Class open. Hello. So some of the glomeruli, it is sclerosed completely. Okay, some of the glomeruli I see nodular sclerosis. Some of the glomeruli I see some expanded mesangium with thick basement membrane. This all can be characteristically seen in one disease. It is called diabetic nephropathy. It is called diabetic nephropathy. You all understand? It is a condition called diabetic nephropathy.
Can you differentiate between the other diseases like
Only the disease which confuses us is actually membranous disease, early stage of diabetes mellitus can confuse us. Okay, membranous glomerulopathy. But immunofluorescence will tell us the clue. Immunofluorescence will be seeing deposits in the membranous glomerulopathy. Whereas here, immunofluorescence will be negative. It will be negative. And another thing is we will be seeing increased glucose level.
critical for this
Diagnosis? Yeah, of course it is critical. If they don't give, for example, there is a mad clinician. He is refused to give the clinical findings. It happens in practice. Okay, so we will call him. He will be in the brain. Okay, so it happens in practice. It is something. So what happens? We will be thinking that it is a membranous glomerulopathy is going for chronicity. But only the clue is sometimes trapping of immunoglobulin looks like a deposit. Understand? IgG trapping is more in diabetic. Since you asked it, I am telling about certain things. So that gives us more confusion. We cannot come to a conclusion. So we have to take the IP number, in-patient number, then we have to follow it up. Then we will get the correct lab findings, results, everything. Then we will conclude. Okay. So that's why it is very, very important when we send a history. Understand? Another disease which confuses is end stage of SLE. Okay, this is lupus nephritis that I am not discussing for you in this module. We need lot of immunological concepts. Inshallah, we will discuss that in immunology. Okay, so another disease, all end stage lupus erythematosus or end stage. Another clue you will be seeing in diabetic nephropathy is vascular changes. Okay, vascular, that I didn't talk here about vascular changes. Inshallah, in the vascular diseases I will talk. That is about vascular changes you will be seeing prominently in the afferent arteries, okay, and medium sized arteries, and we will be seeing some interstitial fibrosis in diabetic nephropathy. That's why we call it is diabetic nephropathy. All the components of the glomeruli, all the components of the kidney is affected. That is, glomeruli is affected, arterioles are affected, arteries are affected, interstitium goes for fibrosis, and there will be mild inflammation in the intestine. Okay, this all can be seen. So that's why we call it diabetic nephropathy. So I am discussing only the glomerular component here. Hello, hello. Okay. So is coming. So this is about diabetic nephropathy. Understand? So this is the scenario of a case. Just I am telling a history and then going to the morphology. Okay, so that you will become master in it. So now again there is a case, like adult and proteinuria, massive proteinuria, and so they want to rule out. Okay, they took a biopsy. In that biopsy, what they are seeing is glomeruli, and in that glomeruli we see capillaries, and there is thick basement membrane, and there is also some deposits in the mesangium, and let us try put deposits in red color, deposits in the mesangium, and there is deposits in the some in the capillaries. Okay, and that is all constricting the capillaries. Okay, this is seen in most of the glomeruli. Okay, it is seen in most of the glomeruli. Okay, some glomeruli the deposits very minimal, some glomeruli the deposits is very dense. Okay, so then they start, it's looking like some abnormal protein. So what they did is the same biopsy material, the pathologist did a special stain called Congo red, okay, and they saw that stain under polarized light, right, and they found there is some green color. There is some green color, apple green color. So then they said it is a amyloid, but then they saw in immunofluorescent it becomes more fluorescence is seen, okay, like deposits, fluorescence are seen. Then they said it is amyloid light chain, okay, AL amyloidosis. Then immediately they asked the patient again, the physician again, and the patient known to have multiple myeloma. Understand? Now if you see this patient, same patient in Congo red, it is producing apple green, and if you see in immunofluorescent and it is negative, if it is negative, then it is called amyloid A. Amyloid A. It is called amyloid A. Okay. See, now you are seeing the same deposits. Understand? Okay. Then it is like a pinkish deposit in hematoxylin you are seeing. Then you are doing Congo red staining. The Congo red staining, it is producing apple green. Okay. Apple green by refulgence in polarized light. Okay. Then you are completely confirming it is amyloid, but you are doing immunofluorescent, you are doing IF. It is not emitting anything, it's not emitting fluorescent, okay. If it emits fluorescent, it is amyloid light chain, okay. If it is not emitting, it is amyloid A. It is amyloid A. Understand? So this is amyloid nephropathy. Why we call amyloid nephropathy? It can even deposit in the interstitium. It can even deposit in the tubules. It can affect other component of the kidney. So it is called amyloid nephropathy. Okay. So these all the conditions will produce nephrotic syndrome. Okay. So what you see in this is in common, there is no inflammation. There is no inflammation. Understand? There is no hypercellularity. There is no hypercellularity. There is no proliferation of endothelium. There is no rupture of basement membrane. There is no proliferation of parietal cells. There is no proliferation of mesangial cells. Okay. So there is no proliferation of, these are the three cells majorly proliferate. One is mesangium, mesangial cells will proliferate, endothelium cells can proliferate, parietal cells can proliferate. Understand? So among all, parietal cell proliferation is dangerous. It is highly dangerous. Understand? So this is about truly nephrotic syndrome. It is about truly nephrotic syndrome. Okay. So now let us take the glomeruli. I am going to draw in a different manner. Okay, this is basement membrane. We have basement membrane. This is the lamina densa. This is lamina rara externa. This is lamina rara externa. This is lamina rara interna. When I say it is lamina rara interna, I should draw the endothelial cells above. This lamina, above the lamina rara interna, you see endothelial cells. You see endothelial cells. Okay. Just below the lamina rara externa, you see the food process. You see the food process. You see the you see the food process. Now Okay, now let us draw in a different manner. This is the basement membrane, right? And this is the lamina rara interna. This is lamina rara interna. And what is this? This is lamina densa. So lamina densa will be dense. And this is lamina rara externa. This is lamina rara externa. Okay, and this is the capillary, and here you see the mesangium. This is mesangium. So this is the capillary cut section. This is the mesangium, and you are seeing the mesangial cells. You are seeing the mesangial cells. Okay, and this is podocyte. This is podocyte, and what you are seeing here is and this is the Bowman's capsule. Bowman's capsule. This is parietal epithelial cells. This is parietal epithelial cells. Understand? Okay, now this person having some problem uh, in the type 4 collagen of the non-collagenous domain. Okay, this is what all I am marking in yellow color is non-collagenous domain. Okay, is having problem in the non-collagenous domain. So this is present in all the throughout the basement membrane, right? This is present in throughout the basement membrane. Okay, now what problem is this guy is having antibody towards that non-collagenous domain. He started forming antibody towards this non-collagenous domain. All the antibody coming and sitting there. All the antibody coming and sitting there, and it is producing a immune complex, right? It is producing immune complex. Now the immune complex is formed, and it is forming all over the basement membrane. It is forming all over the basement membrane. It is like a forming like a line, right? So the deposits are called linear deposits. Deposits are called linear deposits. These deposits are called linear deposits. And if these deposits will trigger inflammatory reaction, because you all know this is antigen antibody complex. What part of the complement system will be activated? What pathway will be activated? Classical pathway will be activated. Then actually C1, antigen antibody complex it is. Okay, if it is only antigen or Ig aggregates, alternate pathway. Okay, if it is antigen antibody complex, it is classical pathway. So it starts with C1q, then goes for C4, C4, C2, C3, C5, 6, 7, 8, 9. Okay, now C4 they release A, right? They release A. So that all will bring the neutrophil. Now we see lot of neutrophil. Okay, so this neutrophil will be attacking this area. Understand? So this neutrophil will attack this area. Okay, now you tell me this antigen is intrinsic or extrinsic? It is intrinsic. It is intrinsic. Yeah, it is intrinsic. Understand? So this is a intrinsic antigen. It is a type 2 hypersensitivity reaction. It's an intrinsic antigen, and it is in situ. It is in situ. In situ intrinsic immune complex disease. In situ intrinsic immune complex disease. Understand? So this is creating inflammation. This is creating inflammation. Don't see the handout. It is creating inflammation. Understand? It is creating inflammation that will produce massive damage to this area. That will produce massive damage to this area. The endothelium will die. Endothelium will die, destroyed. Immediately endothelium will generate. Endothelium will grow back. Okay, the endothelium will proliferate. Endothelium will proliferate, and now it is full of Okay, endothelial proliferation. No, it is not cancerogenic. It cannot produce cancer. Okay, because before that it will collapse very quickly. Understand? So, and it is proliferating. It is proliferating, and it is endothelial hypercellularity is increased. So there is hypercellularity of endothelium and neutrophilic infiltration. Neutrophilic infiltration, and if it is becoming worse, then this in parietal epithelial cell will proliferate. Parietal epithelial cell will proliferate. They will come and literally push the capillaries. Understand? They will come and literally push the capillaries. This whole thing happening due to in situ immune complex formation. In situ immune complex formation. Understand? In situ means something happening in the site. In the site, it is not happening in the circulation, it is happening in the site. The site is glomeruli, the site is basement membrane, the site is which part of the basement membrane? The site is non-collagenous domain of the type 4 collagen of the basement membrane. It is intrinsic, it is type 2 hypersensitivity reaction, and it is activates the classical complement pathway, and automatically it brings the neutrophilic reaction, and neutrophil damage the endothelium, that will produce more endothelium, that leads to endothelial proliferation, that more neutrophil is coming, that is called neutrophilic infiltration, and then the cytokines growth factors are produced, that will go to the parietal epithelium, that will stimulate the parietal epithelium proliferate. So this whole thing happening because of what? In situ immune complex formation. In situ immune complex formation. Understand? So, and this is all about one kind of pathogenesis. This leads to nephritic syndrome, because this leads to hematuria. This leads to hematuria because whole filtering area is literally damaged. That leads to hematuria. And that leads to what happens when there is whole collapse and proliferation happening, that leads to decrease in GFR. Glomerular filtration cannot happen, because glomeruli should be, we need a good filtering area, right? Filtering area is, it is happening in all the millions of glomeruli. It's not happening one glomeruli. Okay, with all the millions of glomeruli, because blood goes to all the areas, right? Antibodies goes to all the areas, and this antibody is going to the NCD domain, okay, which means it is present in all the glomeruli. So all the glomeruli are affected equally, and it will produce massive hematuria, and there is some mild proteinuria or moderate proteinuria, but there is fall in GFR, that leads to increase. That if there is fall in GFR, sodium and water cannot sent out. Sodium and water will be retained. If sodium and water is retained, what will happen to the blood volume? The blood volume increases. Sodium and water is not going out, it is retained. It will increase the blood volume, that leads to hypertension, that leads to severe form of hypertension. Understand? So understand, there is a severe hypertension, and there will be serum creatinine slowly shoots up. Serum creatinine and blood urea nitrogen slowly shoots up, but that will not produce any symptom, that is called azotemia. If it produces symptoms like heart symptoms like palpitation, and gastrointestinal, abdominal pain, and any pain in the joint, any pain in the breathing, pleuritic pain. So these are all the symptoms related to the uremia. Okay, so that is blood urea nitrogen is, the urea is depositing in the tissues. This is called nephrotic syndrome. This is called nephritic syndrome. Yeah, this is called not nephrotic. It is called nephritic syndrome. This is one of the mechanism, that is in situ immune complex. Okay. Now remember this nephritic syndrome. Okay, this nephritic syndrome will manifest in three forms. Okay, what are the form? It may be acute. Okay, in that, okay, there is glomerular basement membrane. Okay, this is endothelium. Now there is inflammation is happening. Okay. Now this antigen is in the blood, okay, the circulation. The antigen is depositing, coming and depositing in the basement membrane. Okay, this antigen is not in the glomerular basement membrane. The antigen is somewhere, due to some reason the antigens are coming. That antigen is coming and depositing in the basement membrane. It is called planted antigen. It is called planted antigen. So then immediately antibodies are formed. Immediately antibodies coming and sitting. That will trigger which pathway? Antigen antibody.
Classic. Classic.
See, antigen antibody complex will trigger classical pathway.
Just
Only antigen can trigger alternate pathway, or IG aggregates can trigger alternate pathway. You should not get confused at all. Understand? So antigen will create, right, also IG aggregates. So antigen and IG antigen surface, right, completely antigen surface. Any exposed, right way of writing is exposed surface of antigen.
Yes.
Exposed surface of antigen and IgA aggregates, immunoglobulin A aggregates can trigger alternate complement pathway. Understand? Antigen antibody complex, immune complex, whether it formed in circulation or whether it formed in situ, okay, it will trigger classical complement pathway. It will trigger classical complement pathway. You all understand? Okay. Now antibody antigen complex is formed. Which pathway will be activated, Nizar? Classical pathway will be activated. In the classical pathway, which is the first complement? Asil?
C1 and then C2.
No, C1, C4, C2, C3. You are wrong three times.
Yes.
Okay, C1, C4, C2, C3, then C5, all B. Okay, okay, all B and except C1. C1 is Q. Okay, then C6, 7, 8, 9 is formed. Okay, now C3, C5B is enough to spoil the area. Understand? Because they can bring the C5A and C3A can bring the neutrophil. Okay. Now this is also in situ immune complex disease because it is happening in the glomeruli. It is happening in the glomeruli. See, intrinsic means if the antigen is there in the glomeruli itself, that is also in situ. If antigen somewhere is getting and deposited, then antibody coming and deposited, then it is in situ. In situ means something event is happening in that place. Okay, that is in situ. Okay, event is happening somewhere and effect is seen here, then it is circulating. Then it is circulating. Understand? See, you understand? Right? So now this is in situ, okay, but it is planted antigen. It is planted antigen. This can be seen. This also leads to what? There is damage to the endothelium, then endothelium will proliferate. Endothelium will proliferate and neutrophil will be coming more. Okay, this is the example we can give. Like if the person got some viral infection, some bacterial infection, he got cured. Okay, after the recovery of bacterial infection, parenthesis, after the recovery of bacterial infection, then all of a sudden the patient, for example, with this child, the patient will come with severe headache. Mother will bring the child with severe headache, and if you ask the question, the child will say that yeah, I go sometimes red color urine. Understand? Immediately we check the urine, there will be massive protein, massive hematuria. Understand? Mild proteinuria. The blood pressure will be, why the headache? Because of increased blood pressure. Blood pressure will be like 160, 110. Understand? 180, 110 like that. So then it is like a malignant, like very severe form of hypertension. Okay, so then immediately if you evaluate it, then if you take a renal biopsy, you will be seeing lot of inflammation and along with endothelial cell proliferation and some kind of infiltration, and if you see in an immunofluorescent, you will be seeing immune complex deposits in the basement membrane, in the mesangium, in the subepithelium, subendothelium, anywhere. It is called post-infectious glomerulonephritis. It is called post-infectious glomerulonephritis. It is due to planted antigen. Understand? Planted antigen, or it may be due to circulating antigen antibody complex coming and depositing in the glomeruli. Okay. So in this case, which complement will be activated? Brother, by the way, what I forgot your name. Sultan. By the way, which complement will be activated?
C1 classical pathway.
Yeah, okay, classical pathway will be activated. Understand? Yes. So this is a case of circulating immune complex disease. Okay. So for example, circulating immune complex disease, I'll give one more example. Okay, you know neutrophil. Okay, you know neutrophil, right? Neutrophil contains lot of lysosomes. A lot of lysosomes, and these lysosomes has lot of enzymes. There are two enzymes you should not forget. One is myeloperoxidase and PR3, protease 3. So if there is some infection coming to this some patient on and off, then yeah, these two things will go to the surface. One is myeloperoxidase and PR3 goes to the surface, so it becomes like an antigen. So our antibodies are produced and they form a antigen antibody complex. They destroy the neutrophil, and now when they destroy the neutrophil, this all happening in the circulation. This all happening in the circulation. Now this when the neutrophils are destroyed, more MPO will be released, more P3 PR3 will be released. Then more antigen comes. You all understand this? Yes. More antigen comes, then more antibody binds. Okay, then it forms a anti-neutrophilic cytoplasmic, because actually it is in the cytoplasm. Anti-neutrophilic cytoplasmic autoantibodies. Why it is auto? It is our neutrophil. It is called autoantibodies. Anti-neutrophilic cytoplasmic autoantibodies are formed. ANCA is formed. This ANCA can come and deposit in the glomeruli basement membrane and can trigger the complement and trigger the reaction. What type of complement is activated here? Okay, again classical pathway. Again classical pathway. Okay, understand? So this is again Sanka associated. Here only thing in immunofluorescent, if you see in immunofluorescent, if it is Sanka, see now I'm telling you, now I'm going to tell you like how I did with nephrotic syndrome. So let us go one by one the scenario. Now this is a child. Okay, we discussed about three mechanisms, right? In situ, immune complex, ANCA. Okay, in situ, immune complex, ANCA, right? So remember, so now there is a child having massive hematuria. There is hematuria and severe headache that is related to the blood pressure increase, that is hypertension. Understand? So this is the symptoms. The patient is coming with us, and the patient is also having oliguria. Okay, which means if you check the GFR is reduced, and if you check the if GFR is reduced, immediately you have to see, your eye should see the serum creatinine. Serum creatinine will be increased. Serum creatinine will be increased. Blood urea nitrogen will be increased. You all understand? Okay, now what immediately the morphology should run in your mind. Okay, what is happening? The glomeruli are there. Okay, and here you okay, draw one glomeruli big. Understand? So you are seeing a capillary, and now you are seeing lot of neutrophil, and endothelium is damaged, and some endothelium are growing back. Endothelium are growing, proliferating. Okay, let us draw endothelium in blue color. Endothelium are proliferating, and this is the scenario in all the capillaries, and we see lot of neutrophils. This is neutrophil, and now I see now I see, right, now the in the glomeruli cellularity is increased due to why? Endothelial hypercellularity and neutrophil infiltration. Okay, now I am going to see in immunofluorescence. I saw in immunofluorescence completely negative, no fluorescence at all, but it shows complete inflammation. Which means they are passive immune. Immunofluorescence cannot detect it. That is more in depth. I don't want to tell the reasons. There are very molecular level explanation. Just now we understand. the immunofluorescence cannot detect it. Okay, if immunofluorescence cannot detect it, it is ANCA associated. It is ANCA associated. Very, very serious form of inflammation. Very, very severe form of inflammation. And if you see this parietal cells also proliferating, okay. See, immunofluorescence here, what you are seeing, dark area, okay. It's not due to our nocturnal issue, okay. It is, see, you are seeing fluorescence, right? Okay. Yeah, see, it is immunofluorescence is dull. See here. Okay, this is all my own real images. Okay, so our real cases. And so what you are seeing here, linear GBM. Okay, linear means antiglobular basement membrane disease. And here you see nothing is there. Understand? It is ANCA. It is ANCA. So all the immunocomplex disease you see immunofluorescence. But in ANCA, it is immune complex disease. It creates inflammation. It creates hematuria. It creates nephritic. But passive immune. It is passive immune. Understand? Okay. So now it is proliferating. The parietal epithelial cells are proliferating, and it is going to construct it. So it is forming a crescent shaped proliferation. If you see this, it is highly dangerous. It is crescentric glomerulonephritis because it will completely obstruct the glomeruli, and it completely, after this stage, fibrosis. Okay, after this stage, it is completely fibrin will come and it will make a fibrosis. So that event happens very, 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 very fast. So that's why we call it is rapidly progressive glomerulonephritis, and the patient serum creatinine will be very high. The patient serum creatinine will be very high, so that can be seen in the lab result. Okay, so this child will collapse and it's very difficult to save. Okay, so this is can happen in ANCA associated glomerulonephritis. Okay, or it can happen in situ immune complex disease like antiglomerular basement membrane disease. You guys are remembering or not? In situ immune complex disease. In situ means intrinsic antigen. Glomerular basement membrane antigen. What is that? Non-collagenous domain. Okay? You guys forgot. See, now we have a basement membrane and we have a antigen, that is non-collagenous domain. It is in situ immune complex, right? So now the antibodies are coming and depositing like this. Okay, now if you see in immunofluorescent, it will produce linear staining. It will produce linear staining, and there will be massive inflammation. There will be massive inflammation. And if the parietal cells are also proliferating, then it is crescentric glomerulonephritis in situ immune complex. Example, antiglomerular basement membrane disease. Example, antiglomerular basement membrane disease. Understand? Okay. Now, even it can happen in circulating immune complex. Okay, I'll give you a history. The patient got pharyngitis. That pharyngitis is due to nephrogenic potential beta hemolytic streptococcal. Okay, beta hemolytic streptococcal infection. That is the one which commonly produce pharyngitis as well as glomerulonephritis. So that patient has pharyngitis, it can have even have skin infection, and after that they recovered, the child is recovered. Then after the recovery of 4 to 5 weeks period, the child comes with severe headache. Okay, then if you do the lab investigation, there is massive hematuria. Due to why? Because this is the capillary, not a glomerular. This is a capillary. In the circulation, there is the antibody complex are there, that is coming and depositing here. Okay, this antigen is streptococcal antigen. So that can come and form antibody immune complex. Or see, now the streptococcal antigen, okay, is gone. After the infection, it should be gone, right? They are given treatment, it is gone. But the antibodies are producing against that, right? The antibody will continue for some period. But this antibody thinking glomeruli as a streptococcal. You understand?
Yes.
That is called cross-reactive antigen. That is called cross-reactive antigen. Understand?
Yes.
So this antibody thinking this is a streptococcal and is coming and attacking. It is coming and attacking. So this is another pathogenesis. So it is coming and attacking. Then immediately what happens? Which complement will be activated? Classical pathway will be activated. Then immediately what will happen? C1, C4, C2, C3. So C3 is more utilized. C3 is more utilized. In this patient, C3 will be less. In this patient, C3 level will be less, and there will be lot of neutrophil. There will be lot of neutrophil and endothelial proliferation, and the glomeruli will be full of cells. Glomeruli will be full of cells. It is characteristically seen in post-infectious glomerulonephritis. It is classically seen in post-infectious glomerulonephritis, and this is the scenario of post-infectious glomerulonephritis. But if it starts producing the parietal cell proliferation, it is called crescentic glomerulonephritis. If you see in PIG and post-infectious glomerulonephritis, crescentic glomerulonephritis morphology, then it is dangerous. It is highly dangerous. How much crescentic glomeruli you see, that much bad prognosis. You all understand, Asif?
Yes.
Okay. So this is about nephritic syndrome. Okay. Now this all deals with classical complement pathway, right? This all deals with classical complement pathway. Okay, now the person is having some respiratory infection, okay, but he recovered. Then he is coming with hematuria. And hypertension and some azotemia. Okay. Then if you see the biopsy, this is the glomeruli, and in the mesangium you are seeing some IgA aggregates deposits. IgA aggregates deposit. It starts like from depositing. When they deposit itself, they produce asymptomatic hematuria. If aggregates are increasing, which complement will be activated? Alternate complement will be activated. Direct C3 will be activated. So now C3 is coming and sitting here. And that will activate what? C3 will activate what? C3 factor B. C3 factor B. Then again C3B. Then they continue. Then they invade the neutrophil, right? But actually here what they do is they proliferate the mesangium. The mesangial cells will proliferate. I told that's why mesangium cells will be 1 or 2 in between the capillaries. Now it will become more. It is hypercellularity. So it leads to mesangial hypercellularity plus mesangial deposits of IgA. So that leads to hematuria. That leads to proteinuria as well. So that's why in immunofluorescent you see IgA deposits. So it is classically it is called as IgA nephropathy or Berger disease. Remember, brothers, this is the most commonest disease. But keep in your mind. And this IgA nephropathy, yani if IgA aggregates are depositing only in the kidney, it is producing hematuria, it is producing mesangial proliferation, it is producing mesangial deposit, it is producing hematuria, it is IgA nephropathy. If these deposits are forming in the skin, forming in the joint, forming in the blood vessels, forming in the gastrointestinal tract, okay, this is produce inflammation all over this area. It is called Henoch-Schönlein purpura. Same pathology. It is called Henoch-Schönlein purpura. You understand this? Okay. Now we will try to finish it with the last one related to the alternate pathway. Now we have a glomeruli, we have a capillary. Okay, this guy is also coming with hematuria, serious hypertension. But if you see him, he is having serious fall of C3. Very drastically C3 is fall. Okay, and what happened is you are seeing dense deposits, okay, in the mesangium, and it is going to the basement membrane. It is called wire loop deposits. See, it is like a wire loop, it is going. Understand? From mesangium it starts, okay, it goes and it splits the basement membrane, it goes in between the basement membrane, it deposits, okay, it deposits intramembranous, okay, it deposits intramembranous, and it happens like all the capillaries, understand, and there will be mesangial proliferation, and even you can see some endothelial proliferation, okay, and the neutrophilic infiltration are mild, okay, and what you are seeing is C3 is fall, okay, and you see lot of C3 deposits in the mesangium, and as well as in the basement membrane, and as well as immunoglobulin deposits, sometimes you can see IgE deposits. So when you see this, okay, what you have to think is there is C3 nephritic factor is increased, that is stimulating the alternate pathway, this is leads to membrane thickening and proliferation. It is called membranoproliferative glomerulonephritis. Since it is thickening the membrane, protein is also lost, so it is called nephrotic nephritic syndrome. Understand? So this is all about nephritic diseases. So what I am asking you guys is go and read the handout today completely. Okay, I don't want to discuss the handout, I want to give you a scenario, I want to discuss the morphology. Understand? So that's why I am discussing it. Inshallah, you go and read it, you will understand it. Okay, then we will discuss further. Okay.